Okay, thank you.
So let's go ahead and get started. Our first speaker is Dr. Ashley Surratt, who is a pediatric emergency medicine fellow at Cohen Children's Medical Center in New York, and is going to speak to us today about an ETOT training in Kenya. Dr. Surratt, please take it away.
Thank you. Okay. Share. Okay. Oops. Okay. All right. Good evening, everyone. My name is Ashley Surratt, and I will be presenting my abstract entitled Assessing Healthcare Workers' Triage Knowledge and Practices in Rural Kenya. I would like to acknowledge my co-authors, Elsie Essien, Rahana Rasul, and Dr. Omalara Uamadimo, all of whom helped to make this project possible. There are no financial conflicts of interest to disclose. The 2017 update by the World Health Organization on Sustainable Development Goals reports that sub-Saharan Africa continues to have the highest under 5 mortality rate, with 84 deaths per 1,000 live births. This is double the global rate. In Africa, at least 25% of pediatric patients present to rural and urban health facilities with a high acuity disease process. Furthermore, it is reported that 1/3 of these children who die before their 5th birthday are dying after the 1st month of life. Moreover, 2017's Sustainable Development Goals reports that between 2000 and 2015, the under 5 mortality rate fell by 44%. Still, 5.9 million children under age 5 died worldwide in 2015. Most of these deaths were from preventable causes. Pediatric deaths in hospitals tend to occur within 24 hours of admission in low and middle income countries. This is largely because these critical patients are not effectively triaged and appropriate interventions are not urgently administered. The WHO developed an emergency triage assessment and treatment guideline, also known as ETAT, in 2005, based on the Advanced Pediatric Life Support Guidelines used in high-income countries. This guide, ETAT, was used to train low and middle-income country healthcare workers the knowledge and skills necessary to recognize and manage critically ill pediatric patients. The fundamental goal of this guide is to decrease pediatric mortality rates by teaching the provider how to categorize patients into those with emergency signs, priority signs, and those with non-urgent cases in 20 seconds or less. More specifically, ETAT focuses on the ABCD concept, which explains to the healthcare worker how to effectively triage, assess, and manage a child's airway, breathing, circulation, coma, convulsions, and severe dehydration with key life-saving interventions such as IV fluid administration and supplementary oxygen. The development of ETAT guidelines was largely created after a study by the WHO in 1998 highlighted significant deficiencies in triage and emergency treatment in 7 developing countries. Many of the common factors that were linked to the lack of efficient emergency triage assessment and treatment included lack of triage guidelines, understaffing, inadequately trained staff, lack of appreciation for the need for urgent medical care, and inadequate facilities, supplies, and medications. In Kenya, there is no formal pediatric emergency medicine training designed specifically for physicians, as most emergency care is provided by clinical officers, who also do not have any specialized pediatric emergency medicine training. Most childhood deaths occur within 24 to 48 hours after hospital admission. Some of the most common and treatable causes of childhood illness and disease are malaria, dehydration, diarrhea, low birth weight, and neonatal sepsis. These illnesses account for 80% of inpatient childhood mortality in Kenya. Based on this data, the Ministry of Health in Kenya developed basic pediatric protocols, which consists of clinical practice guidelines taken from local and international guidelines that would improve childhood mortality by improving emergency and inpatient care in the first 48 hours of hospitalization. The results of this intervention showed that there was a positive uptake of clinical guidelines after training, which resulted in greater compliance and improved patient care. Nevertheless, despite this effort, pediatric emergency care is not widely practiced in rural regions in Kenya, such as Thika Level 5 Hospital. This research project aimed to examine and improve Kenyan healthcare workers' knowledge and clinical practices and barriers to sustainable triage and acute care management through ETAT training sessions, repeated surveys, and assessments. We hypothesized that healthcare workers' emergency care knowledge and triage practices would improve after ETAT training and repeated exposure to these principles with interval follow-up assessments. This project was a prospective longitudinal cohort study at Thika Level 5 Hospital in Kiambu County, Kenya, which is the largest public medical referral facility in the county. It has an inpatient pediatric census of up to 140 patients daily, in addition to 40 to 60 newborns. The study population included English-speaking pediatric clinical officers and nurses without recent ETAT training. This study took place from January 2020 to August 2020. The intervention was a 2-day ETAT training course adapted from WHO ETAT guidelines. The training course included both interactive lectures and hands-on practice of basic emergency skills. The image on the left shows a lecture hall at Thika Level 5 Hospital where training took place. Outcomes were measured using both a knowledge assessment and a healthcare professional survey. The survey was a 10-question scaled response questionnaire directed to identify attitudes and behaviors related to the triage process at Thika Level 5 Hospital. The participants were also given a questionnaire to collect participant demographic data, which included age, gender, languages spoken, educational level and degree, years of experience, years employed at the hospital, and prior ETAT training. The survey and the questionnaire were vetted by the Thika Hospital Administration for relevance within the clinical setting at the hospital. The pre and post knowledge assessments were created by Dr. Heather Krause from Baylor College of Medicine. The questions above are examples of the items from the pretest. The pretest contained 33 questions and the post-test contained 28 questions. Baseline participant data and answers to the ETAT questions were recorded. Each item on the assessment was worth 1 point when being scored. After reviewing all questions, the percent correct was calculated for each time point per participant. Frequency and percent of responses for the healthcare professional survey were tabulated, and trends and changes over responding strongly agree for each were evaluated using Cochrane-Armitage test for trends. These survey and assessment tools were distributed before and 4 times after training, at 2 days, 2, 4, and 6 months apart, or at times pre-test, post-test 0, post-test 1, post-test 2, and post-test 3. The general demographics of the study participants include 24 healthcare providers, 6 males and 18 females, all spoke English and Kiswahili. Only 2 participants received prior ETAT training. Results from a linear mixed model with a random effect for repeated measures showed that participants had averaged 65.5% on the pretest. After training, there was a significant increase of 5.61 to 6.66 percentage points in ETAT scores over time for post-test 0, post-test 1, and post-test 3, with p-values of 0.00, 0.02, and 0.03 respectively. In addition, the results of the survey showed that there was a significant positive trend in participants who responded that they strongly agree to the question, there's a formal triage system in place at Thika with a p-value of 0.03. The results of this study indicate that when trained, healthcare providers in rural Kenyan hospitals can increase their knowledge and triage practices for pediatric emergency medical management. With regularly coordinated ETAT training sessions, we can improve dissemination and retention of important triage principles in resource-limited countries. Moreover, the WHO's Sustainable Development Goals for 2020 indicate or estimate that because of healthcare disruptions due to COVID-19, the childhood mortality rate may increase with hundreds of thousands additional under 5 deaths, with a 100% increase in deaths from malaria in sub-Saharan Africa. I would like to acknowledge the following individuals and groups for their support and contributions, without whom this project would not have been successful. Thank you.
Excellent job, Dr. Surratt. I think we have time for one question, so you can either type it into the chat, or if you'd like to unmute yourself, anybody from the audience, and ask a question of Dr. Surratt. All right, then I'll jump in and ask a question. So if the uptake, it sounds like this was an educational only intervention, yet with that training intervention, you were able to then have a huge increase in the people that reported there was a triage process in place at the hospital. So can you describe a little bit about what triage, whether there was any triage process in place prior to the training, and what the barriers were to that implementation and how this helped overcome them?
Sure. Okay. So when I first got there, I actually kind of observed their whole triage process. So it was a first come, first serve process. So you would go to registration, you would get a number and kind of wait online. And once your number came up, you went and you saw whoever was in the office, a nurse or clinical officer, and they would see you first. A lot of the barriers to triaging in terms of, for example, just getting a basic set of vital signs, they didn't have. So they might not have had a pulse oximeter. There might not be a blood pressure cuff. So they just they weren't getting the vital signs. In terms of someone who would need oxygen, sometimes they didn't have that available either in the triage rooms. So essentially, it was a lot of lack of supplies. The other thing that they mentioned was that they didn't feel like they had any training on proper triage algorithms. So they were really interested, more so than I expected, in actually getting this information. And even I think about 2 weeks ago, one of the participants reached out to me because she wanted me to send her some more materials. So I think they are ready to learn, but they just need more exposure. So that was part of it. So I'd say all in all, it's the educational part, following up and just kind of practicing, because they also felt like even when they do learn things, they don't have the opportunity to practice, and then lack of supplies.
Excellent, thank you. Well, you should be, it's very impressive having implemented triage in lots and lots of places. I can say that I've rarely been able to do an educational initiative with that kind of impact. So it sounds like they were very ready. Nice work. All right, if you want to go ahead and unshare your screen, and we'll.
Can I also ask a question, Matthew?
Yes.
If that's appropriate. Okay. That was really good. That's right. I just wanted to ask you, as far as a plan, as far as I know you did this at one center, but as far as what the there's a plan to expand it to other places, or if what the plan is as far as I asked this because I'm also at heart a global health faculty, and also been involved in a lot of the implementations in most of the sub-Saharan African countries. So I know this has been really successful in so in the South Africa when they started, and then other parts of Africa, but it would be really good to find a way to make this sustainable for at least, and have also an engagement from the ministry, and making it more sustainable, and also expand, because I think what you were able to show is that there's a lot of interest. So if there's a way to cascade it to other areas.
So I just made this slide just in case I got this question, but so I think my future goals for this hospital, it's actually a pretty big hospital, but my goal would have been to train as many providers that wanted the information. And because I was only there for a short period of time, we couldn't get as many people because they also have to work. So I think part of the issue is you need to make sure they're paid for their time, because if they're giving up time to come to a training course, you need to make sure that they don't lose that money. So there requires funding for that. And then training the trainer, I think, is a huge part of this. And then we can go on and measure other outcomes. But I think the whole goal is to, and the other one thing I wanted to do was have small cards that they can use, like badge buddies that a lot of us have here, that they can hang up in all of their spaces in the hospital so that they can refer to it. But again, the major issue was supplies. So one thing I was able to do when I first went over there was get donations from one of my residency programs and the respiratory therapists, because here we throw away so many things if we even open it and don't use it that we could use in other countries. So these would be my main things, is to train as many people and then train the trainer so that you have key stakeholders in the country without you actually being there, so they can keep spreading the information.
That's awesome. Just one thing to add to that, and something that might help you in the process of your expansion, which is, I feel like it's great that you have that plan, is there's a resolution. I'm not quite sure if you're familiar with it from WHO that would ask many countries to fulfill. And I think it really helps for advocating for the work that you do, which is great. And there will be a buy-in and from like the local government side, so that way it could be sustainable and these people can be paid for it, because this is something that all the countries have to eventually report. So it's great. Congratulations again.
Thank you. Thanks so much.
Yeah, I do believe emergency care is a recognized right in the Kenyan constitution, actually. That's what I was told by some EMS people recently. All right, thank you very much. And Dr. Furiu, with that, we'll get you started. So Dr. Furiu is an assistant professor at Columbia University. Dr. Furiu, go ahead and she's going to speak to us about burnout in people that were exposed and got sick from COVID-19 healthcare workers. So please take it away.
Okay, thank you so much, Matt, for the introduction. Can you guys see my screen and can you guys hear me? Okay, great. We last year around this time, we, as you guys, most of you guys know, that New York City was the epicenter of the pandemic. And at the time when we were buried under all the patients and all the amount of stress that we were all witnessing, and you guys, I guess, witnessed from other parts of the country and the world, much of the burden fell on emergency department and ICU, especially at the very beginning, where we didn't have a lot of resources all over the country, and also when we did not know that in places like New York City, the pandemic had spread, and eventually when it was overflowing and burdening the hospital, it felt a bit late. And most of us felt the burden from the patients that we were seeing, and also from the infections that most of us ended up falling ill for the disease, and at the same time witnessing the death and the disability that we witnessed from our patients and our colleagues. We wanted to find a way to share the story and also advocate. At the time, the testing was not widely available, as you guys know, and there were a lot of stress around what we know, and we were learning on the job, especially very early on, right after Wuhan and Italy, and eventually when it came to New York City, we didn't have a lot of evidence. So being at the forefront of this and also trying to see what are some of the factors that are associated with healthcare infection. A lot of us thought maybe this was due to the shortage of PPE, but are there other factors like the number of patients that you're seeing, your clinical setting, and also what are the factors that we wanted to see, what were the factors that contribute to the psychological distress during this pandemic. And this, we performed a cross-sectional survey to assess this, and we disseminated over social media. And I would like to start also by thanking our the co-authors. This was published, and you guys can see the full manuscript on BMJ. So just like I said earlier, most of the what we're trying to do with the survey is trying to assess the factors that were associated with healthcare worker infection and also the psychological distress during the pandemic. So we shared this cross-sectional survey through social media, and we disseminated to all healthcare workers and to everyone that work at the hospital and the pre-hospital setting. We wanted to make sure that we included also the non-clinical contributors, such as the clerks, the security officers, who were also exposed to disease, but felt like they were ousted from most of the research that's been done on when it comes to burnout and healthcare worker infection. And when the survey had a 42-item questionnaire, and it assessed the transmission risk, the patients, the respondents' clinical role, the work environment, and availability of personal protective equipment. And also, we assessed the risk for an anxiety, depression, and burnout. and it was a 5-minute survey that the participants filled out. And based on the results that we were able to get, we assessed the risk factor associated with that. And we were able, as you can see from this slide, most of the respondents were from academia, which applies to most of the SAM audience here. And also most of the respondents were from the emergency department and internal medicine department. And we hypothesized that healthcare workers work in the emergency department and ICU settings would have had the higher rate of infection. And especially looking at the experience we had early on in New York City, we saw many patients with COVID before we even know it was COVID. And some of my colleagues were also infected with COVID before they even knew that COVID had spread in the city. And this was also used as a way to advocate for our specialty. Just the nature of the work and the environment puts at a higher risk. And we wanted this study to show that, and it did. The numbers do not lie. Over a matter of a week, when we disseminated this survey on social media, we used Twitter, Facebook, Instagram, and WhatsApp to disseminate this, and we were able to get over 3,000 respondents in a matter of a week, and we had to close it. Our initial goal was to get around 500 respondents, and at the time, around May, June, most of the respondents that we had were from the Northeast. Also, at the time, the COVID pandemic had not really spread to most of the other parts of the US until June and July. So we captured a lot of the respondents from the Northeast that were exposed to COVID and also end up getting infected, and also, as we can see, had a higher correlation for a risk of infection and burnout. The prevalence of self-reported COVID infection, we were able to assess, in addition to that, also assess the risk of burnout and depression. At the time in May and June, because testing was not widely available, we were able to include only patients that had self-reported COVID-like symptoms. And we included that as part of the respondents who also tested positive for COVID. So the results showed that over 29% of the respondents met the criteria for COVID infection or tested positive. And the healthcare workers work in the emergency department, which is over 31%, which is the highest percentage of infection rate was within the emergency healthcare workers working in the emergency department, followed by the ICU and inpatient setting. And of course, the healthcare workers that were infected with COVID reported higher levels of depressive symptoms and anxiety symptoms and burnout. And so would like to also, most of the numbers I've already shared, but in the conclusion, I think this study has showed that the significant amount of healthcare worker infection, especially at the very beginning when we didn't have the CDC and much of the data on healthcare infection were not available. And this study has shown that risk of infection was as high as 30%. At the time, the CDC had reported only at 20%. So this had shown that the numbers that we're getting from the CDC, especially at the time where the federal government was trying to minimize most of this infection rates, unfortunately, at the time was not very transparent. So the study has shown that the risk of infection among healthcare workers is very high, but also looking at the factors that contributed to the risk of infection, lack of PPE shortage, and also at the same time, lack of support from higher leadership. And also the study has shown that the risk of burnout and anxiety and depressive symptoms were higher in those healthcare workers that had exposure or infection to COVID. Thank you.
Excellent job. So, and congratulations on that work. Please feel free to type a question into the chat or to pop in and unmute yourself and ask a question of Professor Furyu. I have a question while people are thinking of them. The time from infection to the survey completion, and so was that taken into account? And if that was taken into, and if that hasn't been, is there other studies that have looked at that? because what happens to that kind of the symptoms that you reported over time? Do they decrease? Do they stay? That was a question I had when I read the abstract.
So we were just looking at people that had shown the symptoms. Not really, we didn't put the time into account. And as you've seen, most of the patients, most of the responders were from the Northeast, and at the time, a lot of the responders did not have access to testing. So we based it either based on the testing or based on the symptoms. And at the time, if you had any flu-like symptoms or cold-like symptoms, was most likely COVID. So we used that. More studies have now, the past few months, have shown that there's more studies on this now, and they took their time into account to this. But for our study, it was very limited. We just based on the resources available at the time, because this was done in May and June, so it was very early on before it spread to the rest of the states. I don't know if I answered your question, but
yeah, I think you answered that other studies have looked at this. And what have those shown? Are you aware?
Most of them, I mean, the timing, at least I can't remember from the top of my head, but it was done. One was from Vanderbilt and recently from Canada, but I don't know most of it. I don't know if it's widely shared yet. So
it might be an interesting follow-up study if you have 2,000 people that have already filled out the survey.
Yeah.
Any other questions? All right. Well, thank you very much. Excellent work. And we'll move on to Dr. Duggan. Dr. Duggan is a graduating resident right now at Hammer program and is going to talk to us on sleep in our shift workers.
Yeah, hello guys. Let me just get this all set. Let's see. Hold on a second. Oh, hold on, it's doing something funny. 1 second.
Hey, Matt, in the meantime,
Yes.
Matt, this is Nate. Am I in the right session, by the way, Matt?
You are in the right session.
Okay, good. Just checking. I got in recently. Okay, thanks.
We're collecting the highest concentration of chairs at any abstract session, so you stay with us.
Yeah, okay.
Sorry guys, 1 second. Let me just make sure this works. All right. Are you able to see my screen? That looks funny on my end. Does it look funny on your end? Can you see my screen, guys?
Yes.
Yeah, we can see it.
All right, perfect. So hello, guys. I am Dr. Nicole Duggan. I am one of the emergency medicine residents at Hammer. Thank you for having me, everybody, today. I'm actually outside because, believe it or not, it's actually quieter out here than it is inside. So hopefully there's not too much ambient noise. But thanks for having me at SAEM, and thanks for joining in. I'm going to be talking to you today about our team's work looking at sleep deprivation in shift workers, which is kind of a hot topic right now. So let's see if I can figure out how to advance it. There we go. So my team and I don't have any conflicts to disclose. I will say, though, that the sleep buds that we used for this study were donated by Bose Corporation. And then the funding that we used for the rest of the study came from a incubator startup program at our local institution. So those are all of the relevant disclosures. So it's estimated that about 25% of physicians are involved in shift work of some kind. And as I'm sure most of you already know, shift work causes some pretty significant disruptions in sleep and sleep patterns. Over time, sleep disruption can lead to chronic and physical and mental health disorders, including things like burnout, decreased alertness, even errors or effect on your efficiency at work. So despite sleep disruption being a huge problem among shift workers, interventions targeting poor sleep and among employees are actually pretty rare at the organizational level compared to other interventions for wellness. So the goal of our study here was to test the effect of noise masking earbuds on perceived sleepiness, sleep quality, and stress level among healthcare workers. The secondary aim was to also try to measure the effect of sleep bud use on alertness after overnight shifts, and we'll get to kind of how we measured that. So for this study, we designed a prospective single subject design study where emergency medicine residents were our target audience. Participants were first given an entrance survey about their current sleep habits. So they listed everything that they did already, including things like blackout curtains, if they used any sleep buds or any earmuffs or any noise canceling devices already, if they use medications, things like this. And then for the next 2 weeks, they were instructed to just continue to go about those normal sleep habits just as they would any day. Every day, they actually received a text message on their phone with a short survey to self-rate their last night's sleep, how sleepy they were that day, and then how much feeling of tension they had that day on Likert scales. They reported use of any sleep aids that they used the last night, so any of those ones that I listed. And then residents on overnight shifts were approached in the mornings after their shift by research assistants to complete a 3-minute psychomotor vigilance test, which is a measure of alertness. So what that looked like is after a full overnight, after sign out, when there was no more clinical duties, research assistants would approach every resident and have them do a little test that was 3 minutes long that had them kind of click on different boxes and different circles on a screen and see how fast that they could actually respond. It's a pretty validated measure of alertness. After those 14 days of their baseline sleep habits, participants were actually given a pair of Bose SleepBuds and instructed to use them as needed at night or during their sleep times for sleep over the next 2 weeks. So that could mean if you were on an overnight, you could use it during the next day. You could use it during swing shifts. Anytime that you felt like you needed to sleep, they were instructed to use them as they felt was appropriate. So I will say the SleepBuds, so for those of you who aren't familiar with them, so they're noise masking earbuds. They're not noise canceling. And you wear them all night in your ears, and they will block out ambient noise, but they can also play a variety of soothing soundtracks that participants can choose from the app. So it doesn't pipe in music or any other track that is completely selectable by the participant, but there's a set of tracks that are proven to be soothing that they can select from if they prefer. So in those 2 weeks during the intervention period, participants completed the exact same daily surveys and the psychomotor vigilance tests that they did after night shifts as well. So they had kind of a comparison value. And then at 6 months after the study, they received a follow-up survey about their current sleep aid use again and whether or not they were still using the earbuds. So moving on to some of the data. So here's a patient demographics table. So 38 total participants enrolled in the study. And of these, 6 of them actually did not use any earbuds at all. So we excluded them from the study. Another 6 did not complete any surveys during the study period. So again, we removed them from the study. And that left a total of 26 participants enrolled in total in the final analysis. So of these 26 participants, they completed a total of 655 daily sleep surveys for our data points. And then we further excluded any surveys that were taken on post-intervention days where the participants did not use the bud. So during those 2 weeks during the intervention period, if the participants reported no bud use, we excluded those surveys as well. This resulted in a total of 501 daily surveys being included in the total analysis. So participants included in the final analysis were resident physicians from all 4 postgraduate years of a 4-year program here. And 27% of the participants included in the final analysis were female. And then the ages ranged from 25 to 35 years old, which is pretty typical of most residencies. So among the participants who reported using earbuds at least once during the study period, the use of the buds varied pretty heavily throughout the period. So of the 14 days when buds were available, participants used buds for a median of 5 days with a range of 2 to 9 days. And the lowest bud use occurred on the day 1 of the intervention that you can see on the left of the graph here. With 6 out of 26 participants reporting use on day 1. And then it trended up until day 4 when 15 out of the 26 participants used buds that night. And then it remained fairly more or less stable and then a slight downward trend towards the end of the study. So it was pretty variable over the course of the timeline. But even despite our small sample size, our findings actually were pretty promising. So these are beehive plots, which you may not be familiar with. They represent reported Likert scores of participants both pre and post bud use, so in the control and the intervention periods. Ultimately, participants self-reported last night's sleep quality, daily sleepiness. Let's see if there we go. So the last night's sleep quality, the daily sleepiness, and the daily tension all actually had improving trends in the post-intervention period, with ratings for last night's sleep quality increasing by 0.51 points, daily sleepiness ratings decreased by 0.62 points, and daily tension decreased by 0.52 points from the pre to post bud period. So our Likert scale was only on a scale of 0 to 7. So while these changes might seem pretty small, they actually all were statistically significant. For our psychomotor vigilance testing, the alertness data, if you recall, only 7 post-overnight shift residents completed a total of 12 psychomotor vigilance testing during the intervention period. And 6 of the completed PVTs were linked to participants who reported no earbud use. So we had to include quite a lot from the final analysis. So ultimately, we only had 3 participants who both used the buds and completed the PVTs in the control and the intervention period. So the study was actually underpowered to detect any effect. So overall, our data suggests that some noise masking earbuds might help improve perceived sleep quality, reduce daily sleepiness, and reduce daily tension in shift workers. This is actually pretty exciting because this intervention is fairly low risk. It's feasible to implement in lots of organizational settings. And the data is pretty exciting, especially given the really small sample size and the very variable participant adherence to our pilot study. So like I mentioned kind of before, the challenges of our work included variable bud use among participants and only intermittent survey results. And I think part of that was variable resident scheduling, which didn't allow for robust psychomotor vigilance testing data for assessing post-overnight alertness. The way that our residency works is you do overnights in blocks and chunks. And so over a 28-day period, the same resident may only do overnights on, the first half of the month versus the second. So it was really hard to compare individual residents in the intervention and the control periods just because there was not enough data. But that's something to consider for our next study. In the future, our work, we're going to draw from a wider variety of shift workers outside of just residents, so including nurses, ICU staff that works 24 hours, nocturnists as well. And we're going to try to account for irregular scheduling patterns that are not reflective of a resident's schedule. We're also going to use the data from our 6-month follow-up survey to try to improve user experience and user adherence to the buds and the surveys itself. And that it actually might be helpful to, instead of just using Likert scales for self-reported measures, we may try to measure objective indicators of sleep and wellness. Like, for example, you can use a Fitbit or you can have your iPhone, which actually kind of measures objective measures of sleepiness. And so that's something that we can look at in the future. So with that, I'd love to thank my incredible multi-talented team that you can see listed here, as well as our partners at Bose who donated the buds. I obviously want to thank BCRIS for funding our work and SAM for giving me this opportunity to talk about our work. If you'd like to read more about sleep in organizational settings and sleep and shift workers, you can look at this QR code here on the left. And I always love feedback. So if you have any feedback or you want to submit some anonymous questions, you can use the QR code on the right to talk to me more. So with that, I'd love to take any questions. Thank you guys very much.
Excellent work, Dr. Duggan. Please feel free to unmute yourselves and ask a question or two.
I'm not sure if I missed it at the beginning, but were there any incentives besides getting them the earbuds for the residents?
No, it was
Like
funny.
money?
No, we didn't pay them. No. So it was funny. We actually submitted the IRB and got this all started, ages ago. Like at this point, it was almost maybe 1.5 to 2 years ago. But because of the credentialing process and all that, it didn't get started until literally the February of COVID. And that's really when it all started to come into play in Boston. And so people were having stress responses. They were having, poor sleep that was poorer than their baseline in general, just because of what was happening and the uncertainty of the times, like a lot similar to what you were talking about, actually. And so I'm wondering if a lot of people kind of jumped at the opportunity to try something that they maybe hadn't tried before to try to improve their wellness experience. But we definitely in the 6-month follow-up survey got a lot of feedback regarding like the assistance of these buds in this like acutely stressful situation. So that was something we actually obviously didn't account for when we were writing the IRB or designing the study, because who could have predicted?
So yeah. I also have a quick question around using a control group for this. When you're asking people every day about their sleep, you're kind of reminding them to potentially do better sleep habits. And so that, what improvement is due to the specific intervention versus kind of the Hawthorne effect that you're looking at it. Do you have any comments on that, thoughts, or how are you designing your follow-up to account for that?
Yeah, we thought a lot about that when we were designing the study at first. So we knew that our sample size was going to be fairly small, just given the constraints around like how many buds we had and the funding that we had. And so we didn't feel like we were going to have a robust enough group to split it into controls and and intervention groups. And so what we wanted to do is we wanted to have each participant be their own control, because over the course of a month or over the course of different types of shifts, my sleep at least varies. So if I'm working swings or I'm working nights, like my quality of my sleep varies significantly. And so I kind of wanted each person to serve as their own control, at least for this small pilot. We actually are in conversations with the hospital and with Bose as well to expand this to other healthcare workers who may have more variable shifts, or might be only night shift workers or what have you. And so we're going to have a much more robust study group that we can consider including a separate control group in and of itself.
Excellent.
Yeah.
Well, congratulations on the great work.
Thank you.
So we'll bring up our last presenter, Dr. Cooperman, who many of you may have heard of. He is chair of emergency medicine at UC Davis and also runs the PCARN network.
By the way, this is, yeah, thanks, man. I'm just going to share a screen. It is ironic that I kind of started the conference off with a keynote, the big audience, and now we have a very cozy little seminar of 8. So that's very cute, and I'm happy to share my data with you guys. So just give me a second, and I'm going to put this on to, we've all gotten very experienced now with all our different views here, but so can you just see now, you don't see my notes, right? You guys just seeing my screen?
That's correct.
Okay, great. So I'm just going to move the gallery view. Okay, great. So thanks for the opportunity to present the research pertaining to young febrile infants and the risk of serious bacterial infections. And specifically what I'm going to talk about now is the role of respiratory viral testing and its impact on the performance of the PCARN febrile infant rule. And this is research that's funded by the NIH, by HRSA, and the EMSC programs. BioFire provided the reagents for diagnostic assays of the respiratory panels. We have no financial conflicts of interest to report. So the risk of serious bacterial infections, which I'm going to call SBIs, in febrile infants in the first 2 months of life evaluated in the ED is around 8 to 10%. As we know, most of these SBIs are urinary tract infections, but there are some bacteremia and bacterial meningitis. Clinical assessment of these infants is often difficult, as many febrile infants with SBIs may not be ill-appearing. And more recent protocols using newer biomarkers such as procalcitonin have resulted in higher prediction rule accuracy. So in 2019, we derived and validated a highly accurate SBI prediction rule in febrile infants 60 days and younger in the ED. There are 3 objective variables identified in the multivariate analysis: a negative UA, an ANC less than 4,100, and a serum procal of less than 1.72. That was published in JAMA Pediatrics. And to create a simpler, safer rule, knowing that when you create these rules, you overfit them to your data, we rounded the cutoffs to an ANC of 4,000 and a procal of 0.5. And using this simpler rule resulted in essentially identical sensitivity as the original rule, but only 3% lower specificity. So in an additional 1363 febrile infants, we again validated the rule with the rounded cutoffs, and we presented it last year at the SAM. The manuscript is under submission, and the results were super accurate, matching the original derivation validation. You can see the test characteristics there on the slide, and the rule is now ready for implementation. However, as documented in several studies, we know that the presence of a respiratory viral infection lowers but does not eliminate the risk of an SBI. And one can see that the risk of SBI in infants without respiratory viral infections is remarkably consistent at about 12 to 13%. And the risk is decreased in those with documented respiratory viral infections. The last 2 studies attested the presence of any respiratory virus versus none. However, different viruses may be associated with different decreases in the risk of SBIs. So the objective of our study was to determine whether respiratory viral detection modifies the accuracy of the PCARN SBI febrile infant prediction rule in infants 60 days and younger. We conducted a prospective multi-center cross-sectional study in 21 PCARN EDs from 2016 to 2019. We included a convenient sample of infants 60 days and younger with rectal temperature of 38 degrees centigrade or greater. They were evaluated for SBI with a minimum of urine culture and blood cultures. If they did not have lumbar punctures performed, they all received telephone follow-up calls to make sure that no one had bacterial meningitis. Everyone got serum procal, and a nasopharyngeal respiratory panel for multiplex PCR testing was obtained from everybody as well. We excluded those who received antibiotics in the preceding 48 hours, those with critical illnesses, significant underlying illnesses, obvious sources of infection, or if they were premature. We defined a positive UA as positive nitrite or any leukocyte esterase, or more than 5 white cells per high power field. UTI was defined in a standard fashion. Bacteremia and bacterial meningitis was defined by growth of a known pathogen. SBI was UTI, bacteremia, or bacterial meningitis. And IBI, which is invasive bacterial infection, was defined as bacteremia or bacterial meningitis. To standardize the viral testing, we obtained nasopharyngeal multiplex PCR testing from all study participants, which were then shipped to a central laboratory for analysis. In the main analysis, we use what's called binary recursive partitioning using classification and regression trees. It's a multivariate analysis using 10-fold cross-validation, so to kind of minimize the overfit to your data. The variables that we included the 3 PCARN variables, the UA negative or positive, an ANC cutoff of 4,000, PCT of 0.5, and then we included the nasopharyngeal PCR testing, positive for any virus versus negative for all viruses. In other analyses to predict SBI, we performed the card analysis with respiratory viruses, results categorized as negative, influenza, RSV, enterorhino versus other. We also did an analysis to predict SBI using all clinical and laboratory variables, including age, fever, height, and duration, the Yale score, which is a score of wellness appearance, the UA, the nasopharyngeal PCR, white count, and ANC, but we left out the PCT because we're aware that some centers do not have availability of rapid turnaround PCT. And then finally, we did an analysis to predict invasive bacterial infection, that is bacteremia or meningitis, using the PCARN rule variables and the nasopharyngeal PCR testing. So of the 1,363 infants available, 1,231 or 90% met all inclusion criteria. The mean age was 36 days. About a third of them were under a month of age. The mean temperature was 38.4, and most had a well appearance with a Yale score of 6, which is the perfect Yale score. 9% had SBIs, and that's the kind of, well, that's the number you want to see. That's the typical number in epidemiological studies of SBIs in these young and febrile infants. About 8% of them had UTI alone, and 1.9% had invasive bacterial infection, including 0.5% with bacterial meningitis and 1.5% with bacteremia without meningitis. And again, this matches the data in the literature really to a T. Respiratory viruses were detected in nearly 62% of all patients. Now, this figure depicts the overall respiratory viral detection status. The gray bars on the left are respiratory virus negative, and the remaining sequential colored bars to the right are for influenza, RSV, rhino or enterovirus, or other viruses. And you can see overall, 39% of patients did not have respiratory viruses detected. 40% had rhino, entero, and then there was a mixture of influenza, RSV, and other viruses for the remaining. And that distribution also greatly represented patients who did not have SBIs. Interestingly, 67% of patients with SBIs did not have a respiratory virus, meaning that a third of them, 33%, did, with rhinoenterovirus being the most predominant virus among those with respiratory viruses detected. And of note, there was 6 patients with bacterial meningitis, and 1 of them had a respiratory virus detected as well. So in the card analysis, I'm just going to walk you through. Each tree depicts the sequential selection of variables by the software until no further rule accuracy is achieved. And the black filled boxes at the end of this and the other trees to follow are the low risk boxes that cannot be split any further to make them even lower risk. So in this card analysis, in which the software considered the 3 PCARN variables plus the respiratory virus scored as positive or negative, it resulted in the same original 3 variable PCARN model, and that the viral results were not selected as important. And the test characteristics were essentially identical to the original PCARN rule, missing just a few of the same patients as missed before. Now, in this card analysis, we did the exact same thing, except the respiratory viruses were broken down into those 5 categories that I mentioned to you. And in this analysis, the urinalysis was first picked positive as the most important, followed by the procal at 0.5, then respiratory viruses, and then ANC after that. But important to note, if you follow the cursor, the viral status splits on negative RSV versus flu, entero, or rhino if the PCT is less than 0.5, but it splits on flu, RSV, and other versus negative entero, rhino if the PCT is greater than 0.5. And although the test characteristics show better specificity and positive predictive value than the model without viruses, the asymmetric and irregular splitting of the viruses make this model non-intuitive and very difficult to apply. In the card analysis, in which the software considered all of the clinical and laboratory variables except for PCT, we could not build a tree that was sensible, and none of the trees picked viruses as important variables. And then finally, in the card analysis, in which now we're predicting IBI, that's bacteremia or meningitis, and we consider the 3 PCARN variables plus the respiratory viral testing as positive or negative. Here you can see PCT is picked first, and then the ANC, and then finally respiratory viral panel is selected. However, the resulting rule, despite having an outstanding specificity, had a sensitivity for IBI less than the validated PCARN rule, although confidence intervals are somewhat wide. But again, we can't have a lower sensitivity when we're trying to predict bacteremia or bacterial meningitis. So there's some limitations to the study. It was a convenient sample. However, the rates of SBI are identical to previous studies of the topic. There was a limited number of patients with IBIs, but that just reflects the current epidemiology of febrile infants. We evaluated these infants in the ED setting only, and perhaps respiratory viral testing has different utility in the in-hospital or other settings. And there was a limited number of patients with individual specific viruses, but this was the largest prospective study of its kind. So to conclude, the addition of a respiratory viral panel results to the PCARN rule did not enhance the accuracy for SBI. For IBI, the addition of the respiratory panel resulted in increased specificity, but it decreased the sensitivity compared to the PCARN rule. And research is needed to assess the role of respiratory viral testing when evaluating febrile infants 60 days and younger in other settings. And with that, I'd just like to thank my co-principal investigators, Drs. Mahajan and Ramillo, and all the PCARN coordinators and investigators in our data center that make it happen. These studies are based on millions of dollars of grants and hundreds of people participating. And with that, I'm happy to take any questions if there's anybody left.
Thank you very much, Dr. Cooperman. As usual, phenomenal work. It's a rare chance to ask Dr. Cooperman questions, so please jump in.
I'm very thick-skinned. You guys can ask me anything. I've been through, like, I don't know, we had the PEDS research meetings right before the SAM. So I think this is like my 8th presentation in 12 days. So you can.
Oh, so you're punchy and will tell the truth too. Oh my God.
I'll tell the bitter truth, right?
I just have a question. So I don't see a lot of PEDS patients now where I work because we have a separate pediatrics at Columbia. And I just want to also make a disclosure that I have now a 7-week-old. So I'm like few days away from counting the 60 days. And I can relate to your presentation and Nicole's presentation on sleep deprivation because I'm going through both of it. And, you know, I celebrated the 30-day mark. I even tweeted saying, yay, you made 30 days. I'm very, you know, but now I think you made me more anxious about the 60-day. But I wanted to know, not so much from the study, but I think in adults, I know we've seen less risk of other respiratory illnesses during the pandemic. I wanted to ask you if that's the case for PEDS population, and I would assume so, but do you think that would have in any way contribute or change this models that you've built for the PCARN?
Yeah, that's great. Those are really great questions. So first of all, let me just tell you, 7 weeks, you're in the safe zone. When I was a resident, if your baby got a fever, that baby got an LP. Not anymore. Now just get the PCARN rule.
Yeah, I counted
so
that.
You're in the safe
60
zone.
days though, you made me a risk.
No. You're in the safe zone. I also want to say, by the way, your colleagues, Peter Diana is a close colleague of mine. He's the second author of this, and he and I have been researching this together for a long time. But interestingly, fortunately, these patients, so first answer, absolutely. influenza RSV disappeared from our ED, just like in kids, just like it did in adults for you all during COVID. But these data were collected and ended right before the COVID period. So they reflect pre-COVID epidemiology, which is likely to be post-COVID epidemiology. But just so you know, actually I'm the co-PI of a very large federally funded study about COVID in children. And I have a cohort of 200 COVID positive babies that I'm doing analysis. And, you know, I'm just gonna speculate. We haven't done the formal analysis, but the reason I'm interested is they do fine, but I want to know about their CBC profiles. I want to make sure they look like other babies with viruses, so it doesn't mess with the PCARN rule. And it looks like they look like other babies with viruses, but we haven't done a formal analysis just yet.
Well, looking forward to that analysis for sure. I was wondering, you know, you mentioned this, and I'm not sure, but the idea that we have to simplify decision rules to the degree that we've had to in the past, right? This is changing ground right underneath your feet, because now most physicians, and especially, you know, residents and trainees that have graduated in the last number of years, they are used to using clinical decision support tools.
Yeah.
And so simplifying that rule, you know, if you're even sacrificing a moderate or a modest amount of accuracy, may not be necessary in the near future, right?
Yeah, well, Matt, it's a really good question. So just so you know, it's a really important question. First of all, as you know, I'm a decision rule person, but for me, I think that's a misnomer. It's just that we're providing evidence at the point of patient care in a way that we never did before. So I'm one, even though I do decision rule research, I will be the first to say decision rules should never replace your clinical judgment. They're there to empower your judgment. And the power of these rules, and particularly the modern age rules, that's basically this one. And you guys have probably heard of the step-by-step. The investigators are from Spain, good friends of mine, and have similar sort of a rule. But the power is this: we have sacrificed no sensitivity. That is, these rules are the same sensitivity of all of those old rules from the 90s. They were called, you know, the Philadelphia rule and the Boston rule and the Milwaukee rule and the Pittsburgh rule. The difference is all of those required an LP. And with this study, with no LP, the sensitivity is identical. It's just that our specificity is much higher, and it's because of one thing, and that's procalcitonin. Procalcitonin is a great biomarker to rule out disease more than ruling in. So Matt, we haven't sacrificed any sensitivity compared to the old days. We've just raised the specificity, which means less invasive testing than the old rules, which is great for all new babies. And at the same time, I would say these are just there to empower your decision-making and not replace it.
Thank you. Other question? I could sit here and quiz him all day, but I can't do that for him or for anyone else. So please jump in and ask any other questions. We have time for one more question. Okay, then I have a yes or no question for you.
Yeah, go for it.
Nobody's going to jump in.
Yeah.
Is the international pediatric network collaboration in Latin America, are they trying to look at this in a, you know, middle income countries and non-high income countries? Yeah,
you know, Matt, so just for the rest of you, actually we have a paper that's in press I want you to read. I'm one of the co-founders of, it's called PERN. It's a global network that consists of 8 PCARN light networks around the world. And the most recent one is one that Matt's referring to from Latin America. Actually, Matt, I created that network on sabbatical with friends in Argentina. It's a network between Argentina, Uruguay, South America, now it's spread to all of Latin America. And you know what, surprisingly, they have access to procal. You know, it's funny, people all say in the States, oh, but I don't have procalcitonin. Europe has had it for like decades. South America has it. I mean, it's so, and this, the PCARN rule, it's a urine dip. You could just dip the urine, a procal, and you get a CBC. Like everybody in the world has those 3 variables, and that's part of the beauty of it, and it can be tested and validated in other settings. So, and the one other thing I was going to say, because someone had asked me this as well, it's not about the viral testing, is that if you're on a desert island and you had no blood tests and all you had was a viral test, it does definitely lower the risk. So it's certainly a good test if that was all you had. But in the modern day ED, you also have a urine, and you got a CBC, and you got a ProCal, and those just trump the viruses.
Excellent. Well, thank you very much. And I want to thank all of our presenters. You all did an amazing job. I've sat through a number of abstract presentations this round. This was definitely the highest quality group I've been able to see. So thank you very much, everyone, and keep doing that amazing research. And I hope to see you around.
Thanks, everybody.
you.
Nice to listen to you.
Thank you.
See you.